Welcome to episode 82 of the OCDstories.com podcast. Now, this is my second interview I recorded at the IOCDF conference in San Francisco, and it is with Dr. Ariz Rojas. So I've been trying to get on the podcast for a while, and we found time to meet up at the conference, which is ideal really, because it was obviously a lot cooler to record it in person than it is over Skype. And it was great chatting with Ariz. And for those who aren't familiar with Dr. Rojas, she is a licensed psychologist in the Division of Tics, OCD and Related Disorders in the Department of Psychiatry, Icahn School of Medicine at Mount Sinai. And Dr. Ariz was put forward to me by Chris Bear. So Chris was is one of the producers behind the documentary Unstuck. So thank you to Chris. And I wanted to get her on. Later on this year, I will be starting training as a child therapist, in CBT in particular. And I'm looking forward to it. It's an area I'm passionate about. So it was great to ask Ariz these questions for my own learning, selfishly, and also, for you guys. I get a lot of questions from parents asking about advice for their children, and I got to ask those questions to Ariz. I got to answer my own questions, and also, you guys sent in some questions, Lauren, Matthew, and Chris, that I asked on this podcast. We go over several topics about, how does treatment of OCD in children differ from adults, sort of group therapy for children versus one-on-one exposure therapy. That one was interesting for me. When to do exposures with the kids, how not to kind of transmit our own OCD onto our children, and how do you explain anxiety and OCD to kids? And obviously the usual questions, what is an amazing life, the billboard question, etc. I just thoroughly enjoyed this. I think, obviously, if you have a kid with OCD, you will learn a lot from this, no doubt. If you don't have a kid with OCD and you have OCD yourself, I still think you're going to learn a lot. Ariz really knows her stuff with OCD generally, so I think you'll enjoy this. And as always, this podcast is sponsored by the guys at NOCD. It is a ERP tracking app. It's currently only on iPhone, hopefully Android later this year, but it is free. And if you download it through this podcast, so the link will be in the show notes on the podcast page, and also on YouTube, iTunes, etc. If you download it through that link, obviously the guys at NOCD support this podcast financially, and also they give extra money for every download to an OCD charity. So you'll also be supporting someone like the ISDF, OCD UK, or OCD Action. It really helps with tracking compulsions, obsessions, and also an SOS feature. So in the moment when you feel like you're burning down, you can hit that button and kind of guide you through it and out of it. And you can also use it with your therapist to control and measure your ERP hierarchy. So go check that link out on the OCDstories.com/podcast. So without further ado, here is Dr. Ariz Rojas. I hope you enjoy. On the podcast today, I have Dr. Ariz Rojas. Dr. Rojas is a licensed psychologist in the Division of Tics, OCD and Related Disorders in the Department of Psychiatry, Icahn School of Medicine at Mount Sinai. Did I get that right? Mm-hmm. Fantastic. I feel like I overemphasized your surname as well, but welcome to the podcast.
Oh, thank you for having me.
Excellent. So it'd be good to get your story, kind of what made you go into this field of work.
Okay. The funny thing is I like to tell my graduate students this. When I was a young child, I definitely thought I was going to become a surgeon or something of sorts. I never thought I'd become a psychologist.
Yeah.
And it was in high school that I accidentally ended up taking a psychology course, and I absolutely loved it and decided that I was immediately going to major in psychology. I've always been interested in anxiety disorders. I've always been interested in behavioral theory and parent management and stuff. And so when I went to graduate school, I decided that I would emphasize a lot on parent training and parent-child interactions. I knew I was going to be a child-focused individual, but I was very much a clinical researcher. I went to the University of South Florida for my graduate training, and I had the fortunate occurrence of having Dr. Eric Storch kind of come to join the faculty at USF, and I immediately capitalized on this. Like, I love OCD. This is so fascinating. You must teach me. And I really didn't let him tell me no for an answer. And so I got to work with him as he built up his clinic, the Rothman Center for Neuropsychiatry at USF, and I just immediately loved working with OCD patients who have OCD, their families, and really started to love clinical work much more than I had anticipated. So when I graduated, I decided that I wanted to do a postdoc in OCD, and that landed me at Mount Sinai. And I worked under Wayne Goodman, who was the chair at the time. He's obviously a big pioneer in OCD. And I loved it so much, I decided to stay on as faculty there and have been at Mount Sinai since 2011 and really have focused so much of what I do in really building up the child services and being able to not only provide evidence-based care, but actually work a lot with our psychiatry residents, child fellows, and graduate students to really learn the proper way of doing evidence-based practice for OCD, so ERP and family work, and most recently working on having philanthropic type donations to be able to run a lot of our services for free so that we can make mental health care more accessible. So that's pretty much my story.
Excellent. No, thanks for going into detail, and I agree with the whole making it accessible. It's definitely, I think in most countries it needs work.
Yes.
Even in my country, and it's free.
That is true. It's definitely not free in the United States.
No. Well, I'll say it's free. We pay national insurance, but it's cheaper than the health insurance. Okay, so how does treatment of OCD in children differ from adults?
So, working with children is a completely different skill set. And for me, it is so much more rewarding because a lot of adults have onset of OCD in childhood. And so the idea is if you can catch it early on, you provide them with the foundational skills, maybe we're resulting in actually having structural changes in the brain as the brain is maturating. But at any rate, you're not only teaching the child the work, but you're also teaching their families. And so the idea that early intervention really is better and giving these kids a chance. And, the more time they're missing school, the less time they're socializing, learning, academics, etc., and engaging in this terrible reinforcement cycle. The treatment is a downward extension from what we do with adults. So children get the same type of CBT as adults. They get the same type of exposure, but they've lived with OCD a shorter amount of time, and so those connections, that negative reinforcement that happens in OCD, hasn't had the same time to solidify. On the downside, kids are really great at getting their parents to do what they want them to do, and so there's lots and lots of parental accommodation. So when I work with kids and adolescents, I work a lot with their parents. And that would be something that's very different than what I would do with an adult, which I'd primarily work with them individually. Kids don't always come in willingly. And so a lot of what you're doing is also creating some motivation for treatment. A lot of psychoeducation, because children don't always have the same insight that adults do. And when they have an intrusive thought, for example, that they're going to kill a parent, or that if they don't engage in a compulsion just the right way, something bad can happen to their parents. That type of crisis that they're experiencing of that intrusive thought is different than perhaps what an adult might experience, because those are their caretakers. So what would happen if they're gone? Who would take care of them? So I think that with children, we tend to go maybe a little bit slower, although I tend to be a bit of an aggressive clinician, so I go right into exposure. We may emphasize to a lesser extent the coping strategies and more the behavioral strategies. And I think that it's important for children to get a lot of positive reinforcement for being in therapy. So they should get rewards, and their parents should encourage this and not get frustrated with them as much. So I spend a lot of my time doing parent work and then a lot of time doing exposure with kids. But a lot of the times, the exposures are similar to what I would do with adults. And sometimes with adults, I give them the same child metaphors because they tend to get it sometimes a little easier. So,
Yeah. Okay, that's excellent. So on you mentioned about the reward system, could that be as simple as like a sticker chart?
Yeah, absolutely. It could be. I think like teenagers are not gonna like be okay with that. Maybe
Pocket
it's
money.
kind of like, can you get me an iPhone?
Yeah.
And can you get me another iPhone? But with younger kids, the idea is that yes, you can have some type of quick external reward, like a sticker chart. But that sticker chart will only matter if those stickers mean something.
Yeah.
Like, can I trade that in for like, you know, a later bedtime or some movie tickets or Pokemon cards or in New York City, kids like to go to Broadway shows. So can we go see Hamilton, please? And so I think it depends. You know, I try not to make rewards be so much monetary based because not every family can afford that. But I do think it's more about parents being able to show and catch their children using the skills, because that is so great for the child to know that their parents are noticing, and also for parents to notice how, wow, my child's actually doing better in utilizing the skills.
Yeah.
Then you actually have a documented trajectory of how they're doing better. So
yeah, no, that's excellent. Okay, so I believe you do, is it free group therapy sessions now?
So because of a donation that I've received, I'm able to offer kind of 3 cycles per year of cognitive behavioral therapy that's delivered in a group format.
Cool. And how does group therapy differ from, say, individual therapy? Is there benefits to group therapy versus one-on-one?
Yes. So I did a little bit of research actually, just looking on whether or not group therapy results in some change, because we are using the same principles, but we are not giving each kid the same amount of individual attention that you would get in individual therapy, and parents don't get the same amount of attention that you would get in individual therapy. So I haven't really done a head-to-head comparison of individual versus group, but I will have to say that most parents, and a lot of times the kids have told me that group therapy has been so transformational for them, their family, and their child, because children get to see other children with OCD. And so much of OCD is like a silent disorder. And you can't look at someone and know that they have OCD. And for kids to be able to see the diversity of OCD is fascinating. They're like, how can you be afraid of vomiting? Horrible. But they're like, but how can you be afraid of just moving something the wrong way? We don't get that. And so they actually get to have this little discussion about, especially at the beginning of treatment, about how their OCD is different, but then their experience is still the same. And the social support is just so invaluable. So the number one question I get asked by parents is like, is my kid going to catch someone else's OCD? And at least thankfully I can say now that I've been doing this, I think this will be the 4th year, is that no one catches each other's OCDs. The same is not true for tics. Kids with tics do tend to trigger other kids with tics. But what I see is more about this eloquence of children being able to say, well, like when I did this exposure assignment, this was really helpful for me. I think you should do that. And they actually like to educate each other about how to do therapy, but they're also cheerleaders for each other. So part of what we do in the group is a lot of live exposure. And half of the time of group, it's 90-minute sessions, is spent kind of working on some kids' OCD. And those kids get to be facilitators of those exposures. So if someone has, I'll just use an easy example, contamination issues with bathroom, everyone in the group will go to the bathroom. Everyone will touch the floor or the toilet seat. Everyone will say, oh, it's possible, you're going to vomit. I always say if you vomit, we have to record it so that we can all watch it later and kind of use it as exposure. But the kids support each other, and they're the first ones to say, you can't wash your hands, we're going to sit with the distress, and maybe you will get sick, maybe you won't. If you get sick, it's okay, we'll be here to support you. And then we switch to something else. And it also makes exposure more fun. So we get creative with it. I have to keep the attention of oftentimes 6 to 8 kids. So if we're not dynamic and we don't have a lot of praise and reinforcement, it would get boring. And I think sometimes individual therapy can be boring, but it's definitely much more exciting when it's done in a group format.
Yeah, absolutely. I'm sure kids listen to their peers more than they do adults.
Yes, well, they definitely think they're experts. Sometimes I have to correct them when they're wrong, but a lot of times I'm just taken back by how sophisticated they are and how eloquently they can describe what they're experiencing.
I'm not sure if that's like always been the case with children, or this is a new thing of this new because I don't think I was that smart at all as a kid.
Well, they most certainly know how to go out and Google and read stuff, and so they like to come in sometimes with misinformation, but we use it as an opportunity in group to talk about it.
Yeah, absolutely. I didn't have Google and I didn't like to read. So. Okay, so Chris actually wanted to know, do kids like doing ERP together? But we've answered that. Chris also mentioned that you do the exposures with the kids.
Yep.
And he mentioned the case of licking a toilet seat.
If needed, yes. Yeah. So, the problem with cognitive behavioral therapists is that, like, a lot of times they don't get in there with their patients. And so what kind of credibility do you have as an individual if you're saying, like, this thing is something you should not be afraid of, but then you also do not model it for them?
Yeah.
Some people will say that's reassuring patients. I say reassurance is something that is kind of repetitive. So if I can do something with a patient one time to model how it should be done, if I feel that it's reassurance, I can always scale back.
Yeah.
But I also need to be able to be a model for kids in particular. And so I always have a rule that I never ask a patient to do an exposure that I myself would be unwilling to do. So I have had some interesting exposures. We've eaten sour cream and onion crickets. We make fake vomit. We oftentimes lick surfaces and shoes and sit on nasty places in New York City, which is maybe like London, but I'm not sure. I've not been to London, but it's pretty filthy.
Yeah, London's pretty filthy.
We have done Bloody Mary seances together. Bloody Mary has been a somewhat popular thing. It hasn't gone out of style yet, so we do those types of things in group together. But for kids, it actually, when you're doing it as a group, and when you're doing it with the clinician, sometimes is a lower level exposure, and then when they repeat it on their own, it tends to be a higher rated exposure. So.
Okay, great. So I'm usually used to reading from a screen, so these questions being printed out is confusing me. So what have you learned or even changed about your approach about treating with OCD over the last few years? Has anything changed, or kind of what you learned at university is still very much what you're applying now?
I think a lot of so I have been very fortunate to just really be in a wonderful pedigree of just like pioneers in OCD. I also have worked with Tanya Murphy and Barbara Coffey, who are PANDAS experts and TIC experts. And, I think that as I see more patients, I am able to kind of coach and problem solve in the moment much more than I did when I was younger. I probably are a little bit less aggressive than I was when I was a graduate student, because then you're just kind of like fearless, and when you're on your own and it's your own license and your reputation, you're like, okay, I can be a little bit more gradual in my approach. The one thing that's also different for me is how my kids grow up, and they're still my patients. And it's interesting to go through this phase now where my children have now gone into high school. The children that I have seen, or my high schoolers, are now young adults. And the connection that you have with them, and how they love to update you, and how they will still have little relapses or lapses here where, because you have such good rapport, because you've been there with them for so much, that they come back. And that's not anything that I would have anticipated. When you learn CBT, especially in graduate school, it's a very manualized, protocol-driven, 3 months, and then you're kind of done, in and out. And it's different when you are the attending, when you're in the clinician, that you actually, you go through maintenance sessions, and they're your patient really. When families have found someone that has helped their child through something, it's like you become part of their family. And so for me, that's been something that I've learned, is that you have your patient alumni, you have your trainees who then go on to become clinicians themselves, and it become why I love the IOCDF so much is because it's like one big family. Yeah. And that's something that I never anticipated before. Yeah. That your mentors still are the ones that you go to when you're like, I have a difficult case, I still need your help here, help me out. But the treatment itself, I think, it's always been good when done appropriately, and it still is. Yeah. And they still try to make little enhancements here, but there's still nothing better than exposure therapy.
Yeah, Yeah, nothing's been clinically proven as more effective, is it? Okay, so a few 3 questions from Lauren, actually. So she's a mother. The first one is she wants to know what's the latest thinking on the causes of OCD. Obviously, there's pandas, but that aside, just general OCD is there.
Do I know the latest causes? Ooh, they're still trying to figure that out.
I know. Yeah.
I'm not sure we have gained that much in the past year. I attended some talks recently at this conference, and they've said, we've been doing this for 30 years, and we always ask really interesting questions, but the progress is still slow.
Yeah.
I think that reflects a lot of the issues with the funding climate. And so treatment outcome research isn't getting as funded as much, and a lot of neuroimaging is done. But it's actually hard to, enlist patients in studies where they're going to image their brain. But I think that they still believe, that it's more of a neurobehavioral disorder. And I think we've made much more progress in pandas and how that treatment is. But, even in studies of deep brain stimulation, they still are not 100% sure what the targets are for OCD. Okay. And so it's still in progress, unfortunately. But I do think that we do make some progress. The therapy side remains the same. Medications change a little bit more. But, what we know about this exquisite brain of ours is that, we have an idea, but we're still not 100% sure.
Yeah, absolutely. And I'm sure if we knew, we'd probably have created some mega drug that just cures it in one pill. Okay, so she also wants to know, basically the merge the 2 questions. She says her child is now an expert in CBT.
Her child?
Her child, yeah. Uh-huh. And I think she means as in she's done it a lot. And I assume she means ERP in CBT. And she still suffers. So are there any kind of alternatives, other things she could try, or anything, obviously without knowing her case, anything extra she could be doing with an ERP? Maybe, I guess, if there's any cases where kids struggle with ERP and how you help them overcome that or break through that barrier.
Yeah, so one thing is to make sure that the ERP is done correctly. The other part is to revisit whether or not they really are using any cognitive strategies really to help them cope with this. I think, more recently we're starting to find, especially with teenagers, I think, is that they do benefit a lot from emotion. They experience a lot of emotion dysregulation and distress tolerance. And so even with my own patients, I'm starting to kind of move towards referring some of my middle schoolers and a lot of my teenagers and some of my adults to kind of getting some dialectical behavior therapy, because it does capitalize a lot on some of the social aspects that affect all kind of teenagers and tweens, but it does give them some additional strategies for emotion regulation and distress tolerance. It's something that ERP and CBT really doesn't address, and I always feel like you give them the first evidence-based stuff first, and then if we're still having residual issues, then we try to think about what is a function of some of those behaviors, and how might we be able to teach them some additional strategies. And when needed, I do infuse, other things like exercise and yoga and behavioral activation, and sometimes some mindfulness strategies or ACT, depending on what the residual stuff is. The other aspect is I do remind people that OCD is not something that you just have and don't have. As you grow, you encounter different situations and scenarios, and your sense of what is important to you changes. And we know that OCD tends to target things that are most important to the individual. So sometimes it's about going back and reevaluating what is the person struggling with, because it may actually not be OCD. And I have a lot of individuals who overlabel things that are just like, that's life. What? Being a teenager is really rough.
Yeah.
No amount of ERP is going to help that aspect. And so part of it is about learning problem-solving strategies, learning some additional skills. And the other part is acknowledging that, some of the stuff sucks. And we'll try to do what we can to get you through it.
Yeah. Okay, great. How do you, obviously, I've got questions. How do you explain anxiety or OCD to a kid? Obviously, they have it, so they know what it is. But obviously, thinking when I was a kid, I felt very sort of alien and afraid of being psychotic. And now I don't like to stigmatize against people who are are deemed psychotic or have schizophrenia, because it's fairly normal. But that is a fear that many people with OCD have. So I guess if a kid comes to you with those types of fears, is there a way you explain OCD and anxiety?
It really just depends on their age. And, when they're little ones, like 5 years old, I try to make it just very black and white. And even for early childhood, I do focus on this idea that your brain plays tricks on you. And we try to think of other scenarios that, where they've been fooled. For middle childhood, I do still emphasize the fact that, many great psychologists in this area kind of talked about externalizing OCD as something that's more of a false alarm, your fight or flight response being an overdrive, or the fact that you respond like you would a bully, because the whole idea is that you want to try to address the thought-action fusion and create this diffusion. So I try to go with a lot of metaphors and try to use the same metaphors that they might have in their life. So if they're really into sports, I try to think about situations where they were letting anxiety kind of guide their decisions without actually having evidence, and then kind of bringing that back to what is it like to have OCD. And a lot of the times I do talk, especially with more sophisticated kids, about the fact that this is in their brain. Isn't it incredible that you can actually fight against your brain? But they're like, but it's my brain. I was like, I know, listen, I can't tell you what's happening, but I can essentially say we have a fix for this. And I don't go into too much explanation, because the reality is that too much information is not good. They will use it against you and say, well, you know what, you said this is in my brain, so I'm just going to do compulsions all the time. But I do try to use a lot of metaphors. With adults, I can get a little bit more technical, but even still, I default to metaphors, because that is how most people in life relate. And the good thing is, of all of the disorders that I treat, I love OCD because we have such good treatments, and I can actually talk about the fact that most people will get better. So that's pretty much, I think that's how most child clinicians usually approach OCD. And I use a lot of visuals. So with little kids, we would actually draw what the OCD monster bully would look like. And then from here on in, I changed my language a lot by saying, it looks like OCD is bothering you. Right now, you're not answering me. OCD is answering me. Wait, let's try this. Let's start this over. Can I talk to Ralph? Are you here? Okay, because for some reason, that's like this real random OCD person just came in. And we try to make it a big joke. So.
Okay, yeah, I like that.
Oh, I said your last name, not your first
That's
name.
fine,
Sorry,
don't worry.
Stuart.
Everyone, the amount of emails I get that start with Ralph, so all my friends call me Ralphie anyway, so it's fine. So Matthew wants to know, that's a good question, how to avoid transmitting OCD to our children. So he has OCD and he doesn't want to pass it on to his children. And then secondly, how to talk to them about it.
Okay, that's a very good question. Well, unfortunately, what's his name?
Matthew.
Matthew. You can't control your genes. So yes, if you are a parent, there is a probability that your child will go on to have OCD. Children will observe behavior, right? So, and they will also have potentially a predisposition. So the idea is that you can't let your anxiety stop you from having kids or worrying that the children are going to go on to develop OCD. But yes, there is a higher likelihood that his children may have OCD. The thing is that, again, early intervention is wonderful. And I have lots of anxious parents that start to notice signs, and they bring children in, even just for a consultation. And either I assure parents that right now we're okay, but should certain things pop up, bring them in. And other times I say, my God, you picked it up. That is amazing. And a lot of times both parents need to be agreeable to this, because oftentimes the person afflicted with the OCD is the one driving the intervention, like the need for intervention. But usually the idea is that with younger kids, you're really just trying to infuse coping strategies. And so exposure can be helpful, but we don't want parents doing exposures with their children. That's something that a trained clinician needs to do. But parents can teach kids how to regulate emotions. They can model how to be brave. They can model how they think through situations. And I Oftentimes say, if you don't know what to do, get one of these great books that are targeted for children who have some anxiety and have OCD, because it really builds in the coping strategies throughout the book. And children learn best through story format.
Yeah, I guess that could be a good way for maybe Matthew and others to tell, or if they want to tell their young kids about OCD and what it is. Like you said, there's many sort of illustrated children's books that talk about OCD, and although they're aimed for kids with OCD, it could be a good way to understand the parents, maybe.
Yes, and I always tell parents to stop labeling things, because right away they want to call something a compulsion or obsession, and you know what? They're too close to it, and they sometimes overinterpret things, and we as clinicians are unbiased here, and so we can really look for patterns that someone untrained won't be able to see. And there are just children have this like a developmental anxiety that is appropriate. They develop their consciousness, like being conscientious through anxiety, and they also do things in a repetitive way because that's how they learn. And so we have to be careful that we are not over accommodating things that might be anxiety-based, but also not over-labeling things.
Yeah.
So I always say it's okay to get a consultation if you're concerned, but don't go and start saying to your child, oh, well, you have OCD.
Yeah.
Because oftentimes I've had to stop parents by saying, actually, your child does not have OCD, but nice try.
Yeah, that's interesting, the whole diagnosis first, because in theory you can treat without giving the firm label. Someone in my a lecturer, a psychiatrist, came in, and with early intervention for psychosis, he refused to diagnose people under the age of 25 unless it was really severe, because he could give them therapy and treatment without firmly giving them a label, so that it would prevent stigma. Okay, so this question from me is, how can parents better support their children with OCD?
So kids always tell me that the part that makes them most upset with their parents is that they don't listen to them. And so, yes, sometimes kids are right, and what is happening is not OCD. Sometimes they're wrong, and what is really happening is OCD. But parents start to get angry, and they just have these really negative interactions when it's surrounding OCD. And I think the idea is to understand that your child is still a child. Despite how eloquent they are, how high their IQ is, the idea is that their experience is real. And their lack of insight is also real. And parents just take it so personally. And I think there's so much anger and resentment and anxiety, and they project so much fear that like their child's going to be, quote, screwed up, for the rest of their lives. So the idea is I spend a lot of my time telling everybody, like, calm down, enjoy your kid, be patient with them, but listen to what they have to say and validate, because validation is not the same as reassurance. And I think so many times parents don't know what to do. They always are looking for the right thing to do, and it's about emphasizing there isn't one right way to do things, but you have to be patient, you have to be neutral, and you have to listen to your kids and validate that their experience is one that's really difficult. But that doesn't mean that you have to give in to their OCD.
Yeah.
And so many times parents give in to OCD because it's just more convenient for that whatever's happening in that time. And so I also teach parents to also be patient with themselves and engage in self-care, because everybody thinks OCD is something minor to treat, but it is so to have, and it's actually just something that's so insidious and so all-encompassing that it really can just rip a family apart. And so a lot of my time is then again about rebuilding those parent-child bonds and interactions, because your child needs to have trust in you so that you can be there for them for other things that happen that are not OCD related.
Yeah. Okay, great. Few more questions and we're done. So you've got a billboard in New York. You can have anything written on that billboard. What would you write?
This is so not CBT.
No, this is the question that always gets people stuck.
If I can, well.
So it doesn't have to be OCD therapy. It could be anything.
Any billboard for me?
Yeah, it could be in Manhattan. It could be anywhere.
Oh gosh. Well, unfortunately, I will just have to put a nice advertisement for Unstuck, a message that you are not alone, and make some type of mental health advocacy stance here.
Nice. Okay, great. And
Make the easy answer there.
well, yeah, hopefully they raise enough money and they can actually get that billboard. Okay, so for me, this podcast is about, well, for me, recovery is about not just getting rid of OCD or managing it, it's about living the life you want beyond it or with it. So what advice do you have, kind of therapist hat off, kind of human beings, other humans, what advice do you have for them to live an amazing life?
Okay. I always tell my patients, but I really try to believe this, that don't let anxiety control your decisions, because emotions are temporary, but your value system is consistent and stable. And so try not to let emotions cloud or guide the things that you know that you want to achieve in life. You may not be able to achieve everything that you set out to, but most people can set out to accomplish something that is meaningful to them and that they're proud of. And for me, it's about really emphasizing this idea that emotions are temporary, but the type of person that you are is going to be stable. And so if you can just get past that, you can accomplish just so much. And the biggest pride that I have is when I have little kids tell me, like, I told myself that this was temporary, and you want to know what? It was, and I had a fabulous time at like sleepaway camp, or doing my presentation, or asking a girl out, and it's like, yes, that's it makes you so happy.
Yeah. Okay, that's brilliant advice. And last question. This is new. I used to ask it. Someone reminded me to ask it. Basically, is there anything else you'd like to say or share?
Oh gosh. Just whoever's listening, I hope this inspires them to kind of get out, ask the right questions of clinicians, not to be afraid. If you disagree with clinicians, to make sure it's a productive dialogue. And if you don't trust the person that you or your children are working with, then stop. Because I think that to some extent there is some intuition involved in finding the right therapist, but finding the right therapist for you is absolutely key. And it can really change your life. And so I always tell even my own patients, if at any point you're unhappy here, like, you tell me, we'll find you someone else, because your child's health is the most important thing here, and your health is, and your time, right? Time is valuable, especially when we're dealing with children. So don't be afraid to ask questions, because that's the only way that you're going to learn.
Yeah, brilliant. Thank you for coming on the podcast.
Thank you for having me.
No worries.